I'm going to talk about pediatric cardiac and chest imaging. I have some unknown cases here to start the chest lecture. Here's case 1 and the second part of case 1. Case 2. Case 3. Case 4, and the last case. So with pediatric chest imaging, I'd like to talk a little bit about some normal findings in newborns, medical newborn chest diseases, surgical newborn chest diseases, the mediastinum, and a little tiny bit about older children, and then we'll cover the pediatric cardiac. The normal newborn chest is not a little adult chest. The AP and transverse diameters are equal, the ribs are horizontal. We have to account for the prominent thymus in the newborn chest. The heart can usually be a little bit more prominent part of the chest cavity, up to about 65%. And people spend a lot of time talking about rib expansion and how the chest volume is, and I'm not a big fan of counting ribs, but the literature will say that the normal inspiration in a newborn is anterior 6th rib and posterior 8th to 9th ribs. And this is why I don't like counting ribs, because if you look at the patient on the left, they have 8.5 ribs expansion, and the person on the right has 9 ribs expansion. And clearly the person on the right has a much lower volume chest than the left. And the reason is that the ribs are not a static structure. They're moving with patient's inspiration and expiration. So you can count ribs, but keep it in context with everything else that's going on in the chest. We can try to determine the child's age by looking at a chest x-ray, by looking at the skeletal maturation. The first molar ossifies at 33 gestational weeks. The enamel is ossifying. The second at 36 weeks. And the proximal humerus will ossify at more than 36 weeks, with about half of kids having ossified humeral heads at birth and about 80% who are post-term. So here we have a patient that is less than 33 weeks gestation, and you can see that we do not see ossification of the enamel of the first or second molar. Here's a baby that's term. We can see enamel ossification of both the first and the second molar, and we can see a small ossification of the humeral head. So all of these things can be useful as you're trying to come up with your differentials, trying to figure out what the age of the patient is. In relation to the body size, the thymus is the largest at birth, although it actually weighs the most when you're a teenager. It can be very variable in appearance, and a big thymus is a good thing. It is a sign of health. The classic signs that people have described are the wave or ripple sign, which is the soft thymus sort of insinuating itself behind the ribs, or the sail sign, where it just sort of sticks out like a sail. It is a common pseudotumor. It can protrude up into the neck. It can go out of the anterior mediastinum into the middle or the posterior mediastinum. So ultrasound or MRI can be helpful if you're thinking about a pseudotumor, which is just normal thymus in a different position, because it will be homogeneous signal that is just like the rest of the thymus. It can simulate upper lobe pneumonia, as in this case, where you can see that there's a very prominent asymmetrical right lobe of the thymus compared to the left. The way that you can tell that it's the thymus is, number one, if you had a consolidated lung, you would not be able to see the normal pulmonary markings, and you can see them behind here. You can see the normal pulmonary markings behind here, and then it also is in the position of the thymus. If you have a child like this and you have a question, you can oblique them, and if it is a normal thymus, it's an anterior structure, it'll move across, and you'll see the normal aerated right upper lobe behind it. Now, the thymus can be a helpful thing in trying to determine if you have air outside the lung, and you're trying to determine if it's a pneumomediastinum or a pneumothorax. The thymus is part of the mediastinum, so the thymic lobes will be uplifted if you have a pneumomediastinum, and here's a nice example of that. Contrast that with a pneumothorax. Now remember, these babies have their films taken with them laying on their back, and air is going to go as far from the center of the earth as it can, so it's going to be up under the anterior chest wall in patients that have a pneumothorax. So here we can see on this baby that there is a pneumothorax on the left side up against that left heart border. Now, one thing that's a common attempt at fooling you is a skin fold. Remember, especially preterm babies have very lax skin like a puppy, and when they put the plate under to take a film, they can get a skin fold. Those skin folds tend to be whiter and less defined lines. They often will project outside of the chest cavity. You can see normal lung markings usually beyond them, but they can be a fooler for a pneumothorax. But remember, the air is not going to go predominantly laterally when the baby's laying on their back. So I'm going to talk now about some of the medical diseases. The first one is wet lung, retained fetal lung fluid, transient tachypnea of the newborn. There is a normal process when the baby is born that they have to go from being in an aqueous environment to breathing air. And the normal lung fluid clears about a third through the bronchi during vaginal squeeze of delivery, a third through the lymphatics, and a third through the capillaries. So here's a baby that has nearly opacified lungs. They have small pleural effusions, and the heart is a little generous, and there's vascular congestion. Retained fetal lung fluid or transient tachypnea of the newborn is really a diagnosis of exclusion. You have to think about it, and there is a normal process of the lung fluid clearing, but it's only after 24 hours, and you can see that there's marked improvement, that you can say that it's retained fetal lung fluid and not pneumonia or some other diagnosis. So with this, you'll see very rapid clearance. You'll see delayed reabsorption of lung fluid in babies that are born by C-section, if the baby's sleepy because the mom got anesthesia, premature infants who aren't very good at breathing yet, infants of diabetic mothers, and these other less common diagnoses that I've listed. You'll see babies that have tachypnea. They can have retractions and grunting that begins in the first few hours of life and persists for about a day. Usually it normalizes by 2 to 3 days. They may be mildly cyanotic in addition. Radiographically, we'll see mildly enlarged heart and mild vascular congestion as that fluid that was going both through the lymphatics and capillaries and being reabsorbed is coming back through the venous system. You often will see small bilateral pleural effusions. The lung volumes are usually normal or mildly hyperinflated, and the clearance goes peripheral to central and upper to lower. So this brings me now to my talk about medical renal disease and my CHIMP differential, or you can call it a crimp differential if you'd like to. And this is just my attempt to categorize so you don't forget thinking about some of the diseases that can present in the newborn with diffuse medical lung disease. And the big thing is to not forget cardiovascular abnormalities, which I'll talk about on the next talk. So C is cardiovascular, H is hyaline membrane disease, or R for respiratory distress syndrome. I is immature lung, M is meconium aspiration, and P is neonatal pneumonia. Now, you all know that respiratory distress syndrome is common in premature infants. The more premature they are, the more likely they are to have it, and it's due to lack of surfactant. When you don't have surfactant, you can't keep your alveoli open, and you get acinar atelectasis. The membranes will slough, and you'll end up then with the hyaline membranes filling up the alveoli. Remember, though, that the bronchi are fine, and that's why the typical finding of ground glass opacity and air bronchograms is what you usually see. These patients have, because their lungs are collapsing, they have very low lung volumes, and their chest is very resistive. So when you try to ventilate them, you can end up with air block complications. So what do you see radiographically? A premature infant who has reticulogranular opacity of the air spaces and normal aerated bronchi. Their lung volumes tend to be low, the thorax bell-shaped, and they do not have pleural effusions. Now, realize that when you are seeing babies' films, you're never seeing an untreated case of respiratory distress syndrome because these babies are all given surfactant in the delivery room now. Here's a less severe case where you still have low lung volumes, granular pulmonary markings, and central air bronchograms. Remember that the lung volume issue sort of becomes a moot point once the baby's intubated because they're starting to control the volumes. Case 4 that I showed you was pulmonary interstitial emphysema, which is a complication of trying to treat respiratory distress syndrome. They're trying to oxygenate these patients, and sometimes the pressures are such that they end up with air dissecting out of the alveoli into the interstitium of the lung. It cannot be used as an oxygen exchange mechanism there, and it can actually coalesce into subpleural blebs, which is what you're seeing here. Now, this is all a complication of treatment, and that's why there's been so much effort into the high frequency and oscillating ventilators and things, is to try to oxygenate these babies without having to increase the pressure for their ventilation. The complication with pulmonary interstitial emphysema is it can break through and you can end up with a pneumothorax. And here you can see how stiff this lung is, because this is a huge pneumothorax, anterior, lateral, and inferior components, but the air that's in the interstitium prevents that lung from collapsing, so you can imagine how it's preventing air exchange as well. And in fact, the extreme pulmonary interstitial emphysema on both sides cause microcardia in this patient. They are limited in their venous return because of the large volume of the lungs in the chest, and these patients can be hypotensive as a result. One thing that is a very sort of Aunt Minnie appearance is a pneumothorax that's in the inferior pulmonary ligament, which is where the pleura comes up and over the pulmonary artery and back down. And these are not very well drained by any chest tubes, so you have to be aware of them. And it's this typical round appearance right on either the right or left side of the spine. You can get the air dissecting back along the hyla and into the pericardium and get a pericardial effusion, and you can get pneumoperitoneum as well as pneumothorax. Here you can see a huge, huge pneumoperitoneum. And then the worst is where you get an air embolus. Here you can see the heart is supposed to be black. White, it's black because it's filled up with air. You can see air in all the arterial system, and this baby unfortunately did not survive. The long-term complication is chronic lung disease or bronchopulmonary dysplasia, and this is a combination of barotrauma and oxygen toxicity during the treatment for respiratory distress syndrome. And these patients, fortunately, do have a fair amount of lung growth left. And so even if they look really bad coming out of the NICU, they have the potential to have a decent amount of lung that works. And although they won't be high-level athletes, they might not be oxygen dependent for their life. Here you can see this baby at 4 months old has a lot of coarse bronchopulmonary markings, scarring, areas of hyperaeration from bronchopulmonary dysplasia. Here's the same patient at 3 years old, and I don't think that you would recognize that there's bronchopulmonary dysplasia there. And in fact, here's this patient's CT. It's a little busier than you'd like to see, but it's not bad at all. Immature lung can also be called premature accelerated lung maturation. This is seen in premature infants who have in utero stress and have more rapid development of their lungs. This is why OB people will give steroids to babies that they're anticipating delivery, is that they're trying to accelerate the lung maturation. And basically, these are the babies that look like little bitty adult chest x-rays. Because they've been stressed in utero, their thymus has involuted, so it's not a prominent part of the mediastinum. And they are usually breathing just fine. Their lungs are slightly more granular than an adult lung, just because they don't have as many alveoli per cubic millimeter as adults do. So this is the typical appearance, and you'll have a good history, premature rupture of membranes, or that they gave steroids to these babies. Meconium aspiration syndrome is something that you're going to see in post-term infants, not preterm infants. It's not common, but it can be very severe, and children can end up on ECMO to try to relax or to rest their lungs because of severe meconium aspiration pneumonia. When the baby is stressed in utero and their term, they can have a gasp reflex and a poop reflex to that stress. So they end up with fecal defecation and gasping, and that's how they aspirate the meconium. Meconium can end up in the lungs. It can cause bronchial obstruction. It causes a chemical pneumonitis, and that will result in patchy atelectasis and areas of overdistension, just like any foreign body. And then they get a superimposed bacterial pneumonia. They can also have air block phenomenon, so about a quarter of these patients may have a pneumothorax. So you'll look for a term infant, you look for those humeral head ossification centers. The lungs tend to be hyperinflated because of the air trapping these babies get. You'll see patchy infiltrates, and depending on how thick the meconium is, it may look more confluent or more patchy. About a quarter will have a pneumothorax, and their radiographic appearance lags behind clinical improvement. Neonatal pneumonias can be obtained in utero, and those will either be ascending from premature rupture of membranes or prolonged labor, or torch infections. They can be obtained during delivery as the baby is exposed to vaginal flora, and this is where the typical beta strep infection comes in. And then they can be obtained once the baby's born and in the NICU, and there are a variety of organisms involved there. The thing that's different from adults is that babies don't tend to get lobar pneumonias. They tend to get diffuse pneumonias. And one of the big clues that you are dealing with a pneumonia is if you see a growing pleural effusion. And that's usually beta strep infection as well. Now this one, I don't know that you could really tell, is this a pneumonia or is this retained fetal lung fluid? And so often these babies will be followed and they'll be put on antibiotics not knowing which they actually have. And then if they rapidly clear, like I showed you for the retained fetal lung fluid, they'll go ahead and stop the antibiotics. They're patchy asymmetrical opacities. They have areas of hyperaeration, and again, you watch for that growing pleural effusion. So again, neonatal respiratory distress, the chimp differential, but remember, not all of these are the same clinical pathway. You don't think about respiratory distress syndrome so much in a post-term, and you don't think about meconium aspiration in a preterm. But we want to remember to think about cardiac disease and pneumonia in all infants. Let's talk a little bit about surgical lesions of the chest. These are the bronchopulmonary foregut malformations, diaphragmatic hernia, lobar emphysema, and the CPAM, or congenital pulmonary adenomatoid malformation. And these pulmonary developmental abnormalities all fit along the spectrum. On one end, there's normal lung and abnormal vessels, and that's your pulmonary AVM. On the other end, there's normal vessels and abnormal lung, and that's congenital lobar emphysema. The bronchopulmonary foregut malformations, somewhere in the middle of that spectrum, arise from a supernumerary lung bud that comes off during 5 to 7 weeks of gestational age. These are these sequestrations, bronchogenic cysts, things like that. A sequestration is aberrant pulmonary tissue that has no normal connection with the bronchial tree or with the pulmonary arteries. They can be intralobar or extralobar, depending on their venous drainage and whether or not they have a pleural covering. The intralobar, I've listed a slide here that will talk about it, but really we never see this in kids. This may be actually not a true lesion that is a developmental lesion, but it may be an area of reinfected lung that gets bronchial artery hypertrophy. Here's a patient that's an older patient that has a intralobar sequestration, and here's the CT showing areas of cystic change and scarring in the lung, and then an arterial supply from the aorta. Now, we do see extralobar sequestrations frequently. These have their own pleura. They are usually on the left. They can be above, in, or below the diaphragm. They are found in babies, so they are a congenital malformation, and they can be because of the mass effect of these lesions. And there are frequent other associations that often are, they can have coexistent pulmonary sequestration and CPAMs. They can have abnormalities of the diaphragm and also congenital heart disease. Here's a patient where we can see we've lost our left hemidiaphragm on the frontal view, and there's a mass on the lateral view. Here's the MR on this patient showing the supply from the aorta into this sequestration and drainage back into the coronary sinus. Here's one that's below the diaphragm. You can see a cystic lesion on this prenatal ultrasound. Here's the left kidney. After the baby's born, here's this mass that contains both cyst and solid material that we can clearly see is separate from the adrenal gland, differentiating it from a cystic neuroblastoma. At MR, here's the lesion with both cystic and soft tissue, and this was taken out and was found to be a extralobar sequestration. Bronchogenic cysts account for about half of all intrathoracic congenital cysts. They usually are mediastinal. They can be pulmonary, usually in the central third of the lung if they are. And they're lined by bronchial or ciliated epithelium. And the symptoms depend on their size. Here's a small one that you can see, follows fluid signal on this MR, and really pretty innocuous otherwise. Here's a much larger one that at MR you can see that there's marked compression of the trachea as a result of this bronchogenic cyst. Diaphragmatic hernias are very common. You all know that they arise due to abnormality of the closure of the pleuroperitoneal space or the area of Bachdalek, and so they're much more common on the left. The prognosis correlates with the degree of pulmonary hypoplasia. Remember, if the bowel or organs are in the chest, the lung can't grow. In addition, the bowel and organs cause mass effect that pushes the heart to the right, and so you can actually get underdevelopment of the opposite lung as well. When you see these babies born, you'll either see soft tissue density or air-filled bowel in the chest, and you'll see shift of the mediastinum, and you'll see a scaphoid abdomen. Here is a patient that had a diaphragmatic hernia, and you can see the marked shift of the right lung. Now, when they go in and repair these, they do it from the abdomen, and right after, you'll see that they have a very small left lung and a air-filled left hemithorax. And this is not a pneumothorax that you need to call them all into panic about. They know it is going to be that way because there's no lung to fill up that space because that lung didn't have a chance to grow. Here's a solid diaphragmatic hernia that has liver up in it and the bowel that is fluid filled, again causing mass effect to the right. This is case 5, which is a diaphragmatic hernia, and in trying to aerate this baby, a pneumothorax developed in that hypoplastic left lung, and you can see because there's direct communication between the lung or the chest cavity and the abdominal cavity, there's a large pneumoperitoneum here as well. Congenital lobar emphysema is not truly emphysema, as there is no destruction of the alveolar walls. It's due to a bronchial atresia and overdistension of the distal lung by the pores of Kohn and collateral airflow. It usually becomes symptomatic in the neonatal period, initially because it's a fluid-filled mass and then because it's an air-filled mass. And about a half of children will have associated abnormalities that are often cardiovascular. So initially, again, these may be a solid mass right when the baby's born and the fluid is not clearing well from that part of the lung. Later, you see hyperaerated lung. And this is case 1, where you can see that there's a congenital lobar emphysema in the right upper lobe. And if you check here, there's a transverse liver, and actually the bowel is on the right in this baby that had heterotaxy and a complicated congenital heart disease. Here's a bronchogram that shows that bronchial atresia in this patient that has congenital lobar emphysema in the right middle lobe and compression of the right upper and lower lobe. Here's a CT. You can see that overdistended lung with normal vasculature running through it. These tend to be anywhere in the lungs, often upper lobe. Congenital pulmonary adenomatoid malformation is hamartomatous proliferation of the terminal bronchioles. It's a hamartomatous lesion. It has both cysts and solid components. There's a slight predilection for the upper lobes, and there's normal vascular supply. The types are 1, 2, and 3. The cysts are most prominent in type 1, intermediate in type 2, and it's mostly solid in type 3. Type 3 tends to have a poor prognosis. Here's a type 1 CCAM, so this is something you need to consider in your differential when you're thinking about a diaphragmatic hernia, but you can see the large single cyst here. This was not the stomach. You could see the esophageal catheter down in the stomach. What we frequently see now is these infants have CCAMs that you might not pick up on a chest x-ray unless you knew they were there, but you can clearly see on CT. Here there's a very vague density down here, and here's this left basilar type 1 CCAM. But what happens is these babies get their prenatal scans and they have a echogenic hemithorax at 18 or 20 weeks that is a CCAM. And then the baby continues to grow, but the CPAM doesn't. And so by the time they're born, you wouldn't see the lesion anymore, except that you knew it was there prenatally, and when you do the CT, you can see it. They usually still take these out because of the risk of infection, but they're starting to sway a little bit more, sort of like multicystic dysplastic kidney when they used to take them all out, and now they're waiting a little bit more. The divisions of the mediastinum: anterior, middle, posterior, and it's basically a third, a third, a third. Anterior mediastinal masses, to me, those are the 2 T's. We don't see thymus, and we don't see, thymoma, and we don't see thyroid lesions in children the way you do in adults. So we can get rid of those 2 out of the 4 T's, and we're left with terrible leukemia, lymphoma, and teratoma. There are some other things, but they are much less common. Here's a patient who has a mediastinal teratoma, a big mediastinal, anterior mediastinal mass that's calcified. And that can be very helpful to categorize that lesion when you see that calcification. In addition, we can see areas of fat development in this lesion on CT. Mediastinal teratomas are about 10% of all teratomas. They're usually benign, but you can't tell if they're benign or malignant based on how they're looking. Leukemia, very common. Here you can see a child with a large mediastinal mass, a pleural effusion as well, bibasilar atelectasis. Here's the same child a week after treatment for their leukemia, and you can see how much the thymus has involuted. There was thymic infiltration by the leukemia in this patient. So the terrible leukemia lymphoma is the most common cause of a mediastinal mass in an older child, and the adenopathy is usually not isolated to just one compartment. It can be anterior or anterior, middle, and posterior. Be sure to look at the bones and at the spleen for associated abnormalities. Here's a patient with leukemia, and you can see the extensive bony destruction and periosteal reaction, as well as osteoporosis, in addition to the mediastinal adenopathy. Here I managed to find a case of Hodgkin's disease that involved only the anterior mediastinum. There it is there. Congenital thymic cysts are very uncommon, but they have a pretty classic appearance, and so I show it to you here. They're usually asymptomatic. Morgagni hernias are anterior hernias. They're through the space of Larry. They're more common on the right, and they usually only contain bowel. Here you can see the bowel extending up into the pericardium, and here you can see it on the lateral view. These are actually, these type of Morgagni hernias are very common in cats. Here on this enema, you can see that this patient has colon up in the chest. Middle mediastinal masses, A's and B's, adenopathy, and bronchopulmonary foregut malformations. Bronchogenic cyst and esophageal duplication cyst, we talked about those a little bit already. Lymphoma, very common in the middle mediastinum. Here you can see middle mediastinal adenopathy in this particular patient. One vascular lesion that's a pretty common and fairly specific appearance is pulmonic stenosis. The patient will have, because of the water jet phenomenon of the blood going through the pulmonic valve, will have enlargement of the main pulmonary artery and the left pulmonary artery, and they'll have a systolic ejection murmur. Here you can see the domed valve, and it'll have a small central hole, and then you can end up seeing the enlarged main pulmonary artery. 95% of posterior mediastinal masses are neurogenic in origin. So between the three categories, you can get the 2 T's for the anterior mediastinum, A's and B's for the middle mediastinum, and neurogenic for the posterior mediastinum, and that'll get you 95% of the mediastinal masses in kids. Here's neuroblastoma. Especially in chest neuroblastomas, you want to look carefully at the spinal canal and at the neuroforamina because these lesions can extend into the spinal canal. So anterior 2 T's, middle A's and B's, and posterior neurogenic tumors. As a transition into the cardiac talk, let's spend a second talking about rings and slings. There are true rings, and then there's the aberrant right subclavian artery, which will just give you posterior impression on the esophagus. It's a fairly common lesion, about 5%, and it's usually asymptomatic. So when we do an upper GI, if there is a patient who has an aberrant right subclavian artery, you'll see posterior indentation on the esophagus, but that's it. The ones we worry about are the true rings and slings, which are either the anterior impression on the trachea and posterior impression on the esophagus, or vice versa. Posterior indentation on the trachea and anterior indentation on the esophagus. This is the double arch, and this is the pulmonary sling. Here's a patient where you can see that there's a low trachea. If you look on the lateral view, you can see that there is a posterior indentation on the trachea. And this is a patient that has, when we do an upper GI, you can more clearly see that posterior indentation on the trachea and an anterior indentation on the esophagus, and this is a pulmonary sling, which is anomalous origin of the left pulmonary artery from the right pulmonary artery. These patients have a lot of associated tracheal abnormalities, so when they fix the pulmonary sling, they can still have a lot of respiratory issues. They can have complete rings, they can have absent rings, and it can be a real challenge to manage these patients. The lesion is very well described by MRI, as you can see on this transverse image, where that left pulmonary artery is coming off, wrapping behind the trachea, and you can actually see the tracheal stenosis here to go off to the left lung. The aberrant right subclavian artery is the right subclavian comes off distal to the left subclavian, wraps behind the esophagus, and here we can see the posterior indentation on the trachea on this upper GI, and on this MR, this was incidentally found. You can see that right subclavian coming off, crossing behind, and heading off to the right arm. Double arch, you'll see usually that the right arch is higher and larger than the left arch. When you do a upper GI, you'll see the posterior indentation on the esophagus, anterior indentation on the trachea, and also on the frontal view, you usually see the higher right and the smaller left arch impressions on the esophagus. This is the most common symptomatic vascular ring. It usually is an isolated anomaly. Here's a nice example on a CT angio of the double arch, complete double arch here, and you can see the left subclavian coming off here and the right subclavian coming off here. Usually each side comes off of their own arch. So the symptomatic rings and slings are the double arch and the pulmonary sling, and you can differentiate those on the upper GI and then follow it by cross-sectional imaging. The asymptomatic lesion is that aberrant right subclavian artery, which you see fairly commonly. I just want to spend 1 second and talk about cystic fibrosis. This is an autosomal recessive disease at chromosome 7, and they have abnormal chloride transmembrane transport, and as a result they have mucus plugging of the exocrine glands, and they get very poor mucociliary transport. And these are the typical appearances of an older child and a younger child. In a younger child, it can look just like airways disease, just like viral pneumonitis or asthma. So just keep that in your mind. In the older child, you're used to seeing the bronchial wall thickening, bronchiectasis, mucus plugging, inflammation, and hyaluradenopathy in these patients. Round pneumonias are the other thing that are sort of specific to the pediatric population, and this is due to centripetal spread of infection through the pores of Kohn and canals of Lambert. It's usually strep, it's usually in the lower lobes.